Welcome to Dermatology Explained. Today's video presentation is the next part of our video series on autoimmune bullous diseases. Today we'll be focusing on IgA pemphigus. Just as a reminder to ourselves, pemphigus is characterized by an intradermal split. Pemphigus is derived from the Greek word pemphigus, meaning blister or bubble, and it can be categorized into 6 groups. Pemphigus vulgaris, of which there is a reactive form known as pemphigus vegetans, pemphigus foliaceus, of which there is an endemic form known as Vulgo salvigans, as well as a lupus-like variant known as pemphigus erythematosus. IgA pemphigus is the focus of today's presentation. There is also drug-induced pemphigus, paraneoplastic pemphigus, as well as herpetiform pemphigus. This schematic diagram demonstrates the layers of the skin, including the epidermis, the dermal epidermal junction, and the dermis, and there is a zoom up of the adjacent keratinocytes as well as the basement membrane layer to demonstrate the molecules which act to allow these keratinocytes to join with each other. And in the upper part of the skin, in the epidermis, you can see here some important proteins such as desmoglein 1, desmoglein 3, desmocollin, as well as plakophilin, plakoglobin, envoplakin, periplakin, desmoplakin, as well as keratin filaments. Whereas the basement membrane zone and the hemidesmal zones are held together by a different set of antigens, including BP180, BP230, plectin, integrin, laminin, and collagen 7. With regards to IgA pemphigus, the target antigens are in the epidermis, and these include desmoglein 1, desmoglein 3, and desmocollin 1. IgA pemphigus can be further classified into 5 types, which includes subcorneal pustular dermatosis, which targets desmocollin 1, intraepidermal neutrophilic form of IgA pemphigus, which targets desmoglein 1 and desmoglein 3. There is also IgA pemphigus foliaceus, which targets desmoglein 1, a pemphigus vulgaris-like form of IgA pemphigus, which targets desmoglein 3. And finally, IgA pemphigus vegetans, which is thought to be a type of pyodermatitis vegetans associated with inflammatory bowel disease. IgA pemphigus is a rare autoimmune blistering disease characterized by painful and pruritic vesiculopustular eruptions. Due to circulating IgA antibodies which target keratinocyte cell surface components, this leads to a disruption in cell-to-cell adhesion and thus leads to the clinical presentation of IgA pemphigus. As alluded to already, there is 2 major subtypes, which includes the non-classic subcorneal pustular dermatosis, as well as the intraepidermal neutrophilic dermatosis form. It has generally milder disease compared to IgG-driven pemphigus. However, it still requires appropriate management to prevent relapses and potential complications. The underlying etiology is not clearly understood. However, it is associated with several conditions, including monoclonal IgA gammopathy, multiple myeloma, peripheral T-cell lymphoma, chronic myeloid leukemia, and diffuse large B-cell lymphoma. Less commonly, it has been reported to be associated with a number of solid organ malignancies, including lung, pancreatic, laryngeal, and ovarian cancers. There's also an association with HIV infection, Sjogren disease, rheumatoid arthritis, Crohn's disease. It can affect any age group, and the average age of onset is 53 years. It generally affects males and females equally. In terms of the underlying pathophysiology, IgA autoantibodies target desmosomal and non-desmosomal components of the keratinocyte cell surfaces. As already alluded to, these include desmoglein 1, which is attributed to intraepidermal neutrophilic dermatosis, desmoglein 3, which is also targeted in intraepidermal neutrophilic dermatoses, and desmocollin 1, which is the target of subcorneal pustular dermatosis. The IgA autoantibodies bind to the Fc receptor of CD89, and this induces a major inflammatory response, which results in neutrophilic infiltration of the epidermis, and this can cause blistering and pustule formation. The first clinical signs are flaccid vesicles and pustules, which are often subacute. The vesicles and pustules rupture to form erosions and crusted plaques. The eruption tends to follow an annular pattern, and the intraepidermal neutrophilic form has been described as having a sunflower-like configuration. It flavors flexural areas, including the axilla and groin, but it can also affect the trunk, upper, and lower extremities. Mucosal involvement is generally infrequent. Lesions can be painful and pruritic, and systemic symptoms such as fevers, malaise, headache, and weight loss are usually not present. Here are several diagrams which demonstrate the lesions that can present in a patient with IgA pemphigus. On the left-hand side, we can see here vesicles and blisters, pustules, crusts, which are confluent and occupy almost the entire trunk. This is also demonstrated here on the right-hand side as well. From another case, we can see here annular erythematous plaques, which are studded with micropustules and present over the lower extremities. There is also a diagram on the right-hand side of a similar annular erythematous plaque studded with micropustules over the back, with areas showing superficial desquamation. In terms of investigations to consider, this may include a skin biopsy. This may show intraepidermal blister, which may be located subcorneally or suprabasally or in the mid-epidermis. Acantholysis is seen. There's intraepidermal neutrophilic infiltration, resulting in microabscess formation. Direct immunofluorescence demonstrates intercellular IgA and potentially IgG and C3 in the epidermis. Indirect immunofluorescence can be used to detect circulating IgA autoantibodies in the patient's serum. On the left-hand side here, we can see a histopathological analysis of lesional skin, which demonstrates a subcorneal blister filled with neutrophilic granulocytes and erythrocytes. On the right-hand side here, we can see direct immunofluorescence microscopy of perilesional skin, which demonstrates intercellular IgA deposits in the entire epidermis with stronger staining in the upper layers of the epidermis compared to the lower layers. Here is another example of histology, which demonstrates a subcorneal blister containing neutrophils. On the right-hand side, the direct immunofluorescence demonstrates positive IgA deposition in the intercellular zone. Differential diagnosis. This includes classic subcorneal pustular dermatosis, otherwise known as Sneeden-Wilkinson disease. It may appear identical clinically and histologically to IgA pemphigus. However, the direct immunofluorescence study is negative for IgA and may show IgG binding. Other differentials include pemphigus foliaceus, bullous impetigo, linear IgA bullous dermatosis of childhood. This tends to have tense blisters, which are subepidermal, and antibodies against BP180, pustular psoriasis, and dermatitis herpetiformis. In terms of the prognosis, IgA pemphigus has a chronic and benign course and generally responds well to treatment. This is different to classical pemphigus. This difference may be explained by a lower proportion of IgA autoantibody titer and the inability of IgA to inactivate complement via the classical pathway. As a superficial blistering disease, IgA pemphigus usually heals without scarring if appropriate treatment is provided. In terms of management, the drug of choice is dapsone. Acetretin has also been used in combination with dapsone or psoralen UVA therapy. Systemic corticosteroids in moderate doses, topical corticosteroids, PUVA therapy, and colchicine have also been used. Mycophenolate mofetil, adalimumab, and isotretinoin treatment has been described in a number of case reports. Thank you for joining us on today's video presentation on IgA pemphigus. I hope you've learned something interesting and useful from this video presentation. Thank you.